First of all, as cardiac surgeons, we're often inclined to underestimate the burden of AFib. In the same time, coronary disease, heart failure, and AFib have a very complex network of relationships and interplay that one condition affects the other and vice versa, often making the condition much worse than we anticipate. Hi, this is Dr. Mariusz Kowalewski. I'm a heart surgeon from the National Medical Institute, Warsaw, Poland, and assistant professor at Thoracic Research Center, Nicolaus Copernicus University. It's my great privilege to present to you our latest article that is about to be published in Mayo clinic Proceedings, and it's surgical coronary revascularization in patients with underlying atrial fibrillation. State-of-art review that we did in an international group of experts in the field of arrhythmia surgery. AFib patients have been neglected in a way. Well, by neglected, I mean randomized controlled trials performed today have been kind of reluctant to include patients with underlying AFib. Reason being, the patients with atrial fibrillation are often prescribed oral anticoagulation that will often lead to differences in the results of the randomized controlled trials. And surgically, so there's the other issue. They've been long treated as any other patient. Me personally, I do not believe they are any other patient. They're very special and deserve the best of care. Our review has put some guidance into where the future research should be directed, and this probably should be directed to AFib patients, as there are still many gaps in knowledge to be addressed. It's hard to discuss one finding, since this review encompasses the entire issue of atrial fibrillation and coronary disease being together and being strongly linked. In the same time, patients with atrial fibrillation are the ones that will appear often or will appear more often in cardiac surgery departments. We discussed in the review how preoperative atrial fibrillation differs from postoperative atrial fibrillation, and what are the clinical implications, and why indeed the patients with pre-op AF fare much worse than patients in sinus rhythm. The review discusses then the stroke prevention strategies in patients undergoing CABG, which is coronary artery bypass grafting. We discussed the strategies on how to prevent stroke, both pre-op, intra-op, and then post-operatively. We discuss the rationale behind post-operative atrial fibrillation prevention and how to manage post-operative atrial fibrillation. We discussed the role of surgical ablation and left atrial appendage, as these two treatments have only recently become acknowledged, both by the guidelines and by the surgical community, as the treatments that actually the patient stands the one and only, hopefully, one and only chance to have this two addressed. By the two, I mean have the coronary artery disease addressed, and in the same time, atrial fibrillation, arrhythmia surgery could be performed in the same setting. It doesn't often happen, so there are still barriers to performing surgical ablation, and there's still barriers to performing left atrial appendage occlusion in this very group of patients that are patients undergoing CABG surgery. But we discuss why that happens and what could we do, or what can be done to have this improved. The patients undergoing CABG and having underlying AFib are the patients at very high risk. And this risk is underestimated. It's not, or the AFib is not included in the surgical scoring sheets that we use in Europe. There's Euroscore. And That's a pity because we often underestimate the risk of the patients. We discuss on the surgical techniques that should be employed while the patient is being operated. We discuss the benefits, the harms of on-pump and off-pump techniques. We discuss the graft selection. We discuss complications, oral anticoagulation, and how to manage it, both pre-op and post-op. Finally, we outline what are the long-term results of patients with AFib that undergo coronary surgery. Atrial fibrillation is not an addition to coronary disease. These are two independent conditions, however, very closely linked together. And in the same time, atrial fibrillation should not be treated as addition to CABG surgery. Indeed, atrial fibrillation is as deadly as coronary disease, and at least similar weight should be assigned to both these conditions. And CABG, or sternotomy to be precise, offers a chance to address AFib in most effective way, and in the same time being safe. Clinically, the procedure has to be planned ahead if possible. The choice of grafts discussed, ablation and left atrial appendage occlusion considered, and oral anticoagulation, antiplatelet therapy discussed with the patients or also within the heart teams according to stroke and bleeding risk of the patient, so that the patient can in the end benefit in terms of hard endpoints like stroke and mortality, but in the same time in terms of quality of life, there's the angina symptoms being relieved, and also the patient free of antiarrhythmic drugs and oral anticoagulation in the end of the day. So what does this finding mean for the patient? Well, patient, first of all, deserve to know what the options of treatment are. They need to know that AFib carries an additional risk that is not addressed by some of the risk calculators, and the risk that we present to a patient before the surgery may often be underestimated. These patients have higher risk of sustained AFib postoperatively if it's left untreated. They have higher risk of early graft failure when vein grafts are selected for the procedure. They have higher risk of stroke and mortality, both early after surgery and in the long term. Finally, they have higher risk of surgical bleeding and early complications resulting from higher baseline risk. So today, not many randomized controlled trials of high quality have been performed in patients with underlying atrial fibrillation. And what we know about the patients undergoing CABG with underlying AFib derives mainly from observational studies. However, recent years have addressed this issue, and more and more randomized high-quality evidence have been made available. Just to mention the last 3 trial that addressed stroke and systemic embolism in long-term follow-up after left atrial appendage closure, Atlas trial that addressed left atrial appendage closure in patients at high risk of developing postoperative AFib, and finally the LEAPS trial will probably address left atrial appendage closure in patients without atrial fibrillation, but otherwise high risk of stroke. None of these studies are dedicated to isolated CABG surgery. None of these studies have addressed in a randomized fashion concomitant ablation techniques. We know that the MACE-4, that is the ablation lesion sets, is the best, but going on pump and heart arrest to perform all the lesions required may not be the safest option for high risk, otherwise isolated CABG case. So we need to define what the optimal lesion sets for the surgical ablation may be, and we need randomized trials for that. We need to define the role and the value of off-pump ablation techniques, including minimally invasive and hybrid approaches in CABG population. We need to define optimal graft selection, and finally, we also waiting for the new atrial fibrillation guidelines that will hopefully assign higher class of recommendations to both concomitant surgical ablation and left atrial appendage closure. Thank you very much.
We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.